Refeeding Syndrome. Insights and Guidance, a discussion on pathophysiology, risks, and management. Welcome to today's episode, where we delve into the critical topic of refeeding syndrome, an often overlooked but potentially fatal metabolic disturbance that can occur when nutrition is reintroduced too rapidly in malnourished individuals. Join us as we explore the science behind this condition, examine who is at greatest risk, and discuss best practices for prevention and management. Let us begin with the pathophysiology of refeeding syndrome. During periods of starvation, the human body adapts by shifting its metabolism from using carbohydrates as the primary energy source to relying on fat and protein stores. This transition leads to a decrease in insulin production and an increase in glucagon activity. Over time, the body's cells become depleted of essential electrolytes such as potassium, magnesium, and phosphate, even if blood levels appear deceptively normal. Deficiencies in vital vitamins, including thiamine and other B vitamins, often develop as well when nutrition is suddenly reintroduced, particularly in the form of carbohydrates. The body responds with a surge in insulin secretion. This triggers a rapid movement of electrolytes, potassium, magnesium, and phosphate, into cells and out of the bloodstream, resulting in dangerous drops in blood levels. The sudden need for thiamine, a vitamin crucial for glucose metabolism, can precipitate neurological complications such as Wernicke's encephalopathy if not adequately supplemented. Fluid retention is also a common issue, which may lead to heart failure or pulmonary edema in vulnerable individuals. Who are the individuals most at risk for refeeding syndrome? High-risk categories include those who have experienced prolonged starvation, such as people suffering from anorexia nervosa, chronic alcoholism, or victims of famine. Patients with critical illnesses, including those recovering from severe infections, major surgery, or extensive burns, are also susceptible. Those with gastrointestinal disorders such as Crohn's disease or individuals with short bowel syndrome, as well as cancer patients who have experienced significant weight loss, must be carefully monitored. Social deprivation is another risk factor, with populations such as the elderly, prisoners, and persons experiencing homelessness particularly vulnerable. Clinicians should be alert to several key indicators that signal elevated risk for refeeding syndrome. These include a body mass index below 16 or a recent weight loss well above 15%, extended periods of fasting longer than 5 to 7 days, and pre-feeding electrolyte levels, potassium, magnesium, and phosphate, that are already low. The clinical manifestations of refeeding syndrome can be swift and severe. Cardiac complications may arise, such as life-threatening arrhythmias or heart failure. Neurological disturbances can include confusion, seizures, severe muscle weakness, and syndromes like Wernicke's encephalopathy. The respiratory system may be compromised, with weakness of the diaphragm leading to respiratory failure. Hematological effects, such as hemolysis due to low phosphate levels, and acute kidney injury caused by low potassium, also represent serious concerns. Of particular note, hypophosphatemia, a marked drop in blood phosphate, can be immediately life-threatening, leading to respiratory or cardiac arrest. Preventing and managing refeeding syndrome requires a careful and deliberate strategy. Before reintroducing nutrition, healthcare professionals should assess the patient's risk using established clinical guidelines. Electrolyte levels, including potassium, magnesium, and phosphate, should be checked and any deficiencies addressed gradually. Avoiding rapid intravenous correction. It is imperative to administer thiamine, typically between 200 and 300 milligrams by injection, before commencing feeding. During the refeeding process, the principle is to start low and proceed slowly. Caloric intake should begin at approximately 10 to 20 kilocalories per kilogram each day, representing roughly 50% of the target intake at the outset. Fluid intake should be restricted and body weight closely monitored. Electrolyte levels must be checked every 6 to 12 hours for the first 72 hours to ensure stability. Vitamin supplementation is essential, with daily thiamine and a comprehensive multivitamin regimen to support metabolic needs. Should complications arise, swift intervention is necessary. Severe hypophosphatemia is treated with intravenous potassium phosphate, while hypokalemia and hypomagnesemia are managed with appropriate intravenous supplementation of potassium chloride and magnesium sulfate, respectively. The prognosis for refeeding syndrome underscores the importance of vigilance. Without proper management, mortality rates can reach up to 6%, particularly in intensive care settings. Recovery relies on the gradual escalation of caloric intake over 5 to 7 days, allowing the body to readjust safely. As we conclude this episode, let us emphasize several key takeaways. Refeeding syndrome is preventable when nutrition is reintroduced with care and vigilance. The most dangerous complication remains hypophosphatemia, and thiamine must be administered prior to feeding in at-risk patients. Aggressive electrolyte monitoring during the initial 72 hours of refeeding is essential to safeguard patient outcomes. Thank you for joining us in this important discussion. For more in-depth episodes on surgical topics, be sure to subscribe and share your thoughts in the comments section below. See you on the next episode of the Everything Surgery podcast. Dissect the extraordinary.